Hi, this is Dr. Perry Carpenter. I'd like to thank you for joining me on today's program. Today's program is from the Special Population Series, and today's program is entitled Exercise Prescriptions for Orthopedic Injury and Rehabilitation Clients, or in our case, we could refer to those as chiropractic patients. I have a fascinating program for you today, and it's a program that I'm sure will provide invaluable information for you as you handle your chiropractic patients that have specific conditions that require your help in the rehabilitation of those conditions. And let me just take a moment to introduce myself to you. This is Dr. Perry Carpenter. I'm a chiropractor. Been a chiropractor for approximately 28 years now. I graduated from Palmer West College of Chiropractic. And throughout the years, I've taken many different types of continuing education courses. And I list for you here some of the courses that I've completed that qualify me to speak on today's topic. And specifically, I'm going to be making extra reference today to materials derived from the National Strength and Conditioning Association, of which I'm a member. I hold two credentials with the NSCA. I hold the Certified Strength and Conditioning Specialist credential and also the Certified Special Population Specialist credential. And today's material is largely based on ideas, references, and concepts about rehabilitating and treating persons who qualify as special populations. And today we're talking about that group of special populations that we find in the chiropractic practice, and that is people who have healthcare issues. Specifically, today we're talking about injuries and issues with the musculoskeletal condition. So today's program is about injury, orthopedic, and rehabilitation patients. And those certainly qualify as special populations. And those are certainly people that have special and unique needs, perfectly suited to the work that we do as chiropractors. So I'm going to be supplementing chiropractic material today with additional material derived from the exercise sciences. And I will be quoting some references from the National Strength and Conditioning Association. References for today's program are many, and draw your attention to a couple of textbooks from the National Strength and Conditioning Association. I'll be presenting information from the Essentials of Personal Training and also the Essentials of Strength Training and Conditioning. I'll also draw upon material out of Lippincott's Primary Care Orthopedics, 2nd edition. I'll refer to Yoakum and Rowe, Essentials of Skeletal Radiology, specifically when we get into a discussion later on the rehabilitation of spondylolisthesis and spondylolysis. I'll be drawing on some physical examination procedures from the Fundamentals of Musculoskeletal Assessment Techniques. That's a fabulous textbook by Palmer and Epler, a couple of physical therapists. I'll make also a brief reference to the AMA Guide's 5th edition, and those of you that are qualified medical evaluators, you'll recognize those references. And then I have a couple of specific references for you relating to the shoulder and the lumbar spine. And I chose and selected these references for a couple of different reasons. Number one is they relate exactly to topics that we're going to be discussing, specifically related to the lumbar spine and specifically related to the shoulder. And also because each of these articles illustrates some general principles that are extremely important principles that we understand regarding injuries and rehabilitation in general. And I'm going to make early references to each of these principles early in the program. And then when it comes time, when we get to the lumbar spine section and when we get to the shoulder section, I will reiterate these principles by drawing upon these references, specifically as relates to the region that we're considering, whether it be the shoulder or the lumbar spine. And I know you're going to find these references to be fascinating, and these are some principles that are illustrated in these references that you can rely on and that you will rely on in your practice from now to forever. So let's talk first about so-called lumbago. Now, lumbago is a term that generally describes non-specific lower back pain. Non-specific lower back pain. In fact, that's a term that's sometimes used in the literature, non-specific lower back pain. Well, we call that lumbago. And this is a term that the lay public is generally familiar with. So let's talk about this generalized, non-specific lower back pain that seems to afflict so many of our patients. Well, with lumbago, pain is generally localized to the lower back. In the lumbar spine region, it may radiate out into the flanks, the so-called flanks or the paraspinal muscular regions. And depending upon the pain generator tissue or the painful structure, pain can radiate from the lumbar spine out into the buttocks, can radiate out into the posterior thighs, can radiate to the lateral thighs, and can radiate down the legs really in almost any distribution, terminating at about the level of the knees. And as chiropractors, we're familiar with many different lumbar spine conditions that can cause radiation of pain down into the legs to the level of the knees. There is only one condition, however, that can refer pain below the knees, and that is radiculopathy. And we'll talk about radiculopathy in a couple of minutes, but be prepared to have your patients report strange distributions of pain in the buttocks and in the thighs and the lateral thighs and even sometimes in the anterior thighs. And this radiation of pain is a non-dermatomal radiation of pain. It's more associated with irritation of connective tissue and sclerotogenous structures. This is referred to as a sclerotogenous referral pain pattern. Now, lumbago is most common in the 20 to 50 year age range and is the most common cause of disability in the less than 45 years old age range. And so this is a condition that chiropractors are familiar with and that we treat every day. Now, causes of generalized lower back pain can be many. It can involve either an acute or a chronic sprain strain injury, and it's the chronic sprain strain injury that's most concerning because the chronic sprain strain injury represents recurrence of painful lower back pain episodes. And when we have recurrence, we know that there is degenerative change taking place in the spine, including the muscles of the spine. And I'll share with you the results of a fascinating study that document degenerative change and loss of function of lumbar paraspinal and deep paraspinal muscle function. Lumbago can be caused by muscular hypertonicity in the form of pathologic muscular stabilization of the spine. Generally, we think of the spine as being the bony stabilizer. Well, in the presence of pathologic changes to the lumbar spine, the muscles assume added stabilization role, and they can become shortened, contracted, and hypertonic. And this itself can be a cause of pain. This itself can result in painful trigger points within the paraspinal muscles. Those can be a cause of lower back pain. Either too much mobility or too little mobility of the lumbar spine can be a cause of lower back pain. We know also that dysfunction, subluxation, and um, hypermobility of the sacroiliac joints can be causes of lower back pain. And then anomalous configurations of the lumbar spine are also causes of lower back pain. And I mention this here to you because I want to encourage you to quicken your thinking toward the presence of possible anomalous configuration of the lumbar spine in those cases where your patient presents with lower back pain that is out of proportion to any precipitating event or any causative event. So, for example, your patient may come in and say, for example, I'm just making this up, but they may say something like, yesterday I was in my garage and I was moving some boxes and they weren't really heavy. But I moved about 10 boxes from one side of the garage to the other side of the garage, and I stacked them. And I didn't think anything of it at the time. But today, today, I'm in pain and my back is locked up. Anytime there is symptoms that are seemingly out of proportion to any causative incident or episode, it's likely that there's an anomalous configuration of the lumbar spine that has been aggravated by activities that otherwise would be inconsequential. They would be inconsequential in the presence of a normally configured lumbar spine. So I encourage you to quicken your thinking as to the possible presence of an anomalous configuration of the lumbar spine. And this is one reason why chiropractors in general, and I always order a lumbar spine x-ray in the presence of unexplained lower back pain. I say unexplained, meaning that the pain is out of proportion to any precipitative incident or episode. So think anomaly. Think anomaly. Okay, so let's talk about the physical examination for patients that present with lumbago. Now, typically, the physical examination associated with generalized and nonspecific lower back pain is going to have a normal neurologic function. Lumbar spine nerve roots and lower extremity peripheral nerve function will be completely normal. So, patellar reflexes will be normal. Hamstring reflexes will be normal. Achilles reflexes will be normal. Sensation will be preserved in all dermatomes. And motor testing of lower extremity myotomes will be normal. Now, it's possible to have some areas of weakness of lower extremity manual muscle testing. However, that weakness is more associated with localized lower back pain rather than being due to any dysfunction of lumbar spine nerve roots. So check your motor examination very carefully, and you'll find that any weakness that does manifest would typically be due to pain with resisted hip flexion, or possibly even pain with resisted knee extension, but that pain and weakness is due to reflex inhibition from lumbar spine pain and is not due to dysfunction of lumbar spine nerve roots. So the point is that the neurologic exam is generally normal. You may find some losses of range of motion, typically will be in either flexion or extension, possibly even side bending to the involved side would show you some reduced range of motion. A key objective finding for painful lower back condition is the presence of antalgia. And antalgia is a Greek word, means away from pain. So when a person has a painful and hot lumbar facet, for example, on the lower right side, they will lean away from the right side. They will lean away from the pain and move toward their left. This is known as antalgia. And antalgia is a form of muscle guarding to protect and to prevent worsening of a painful structure, whatever that structure may be. So you want to check circumferentially around the examinee for antalgia, because the antalgia gives you a strong clinical finding for where the pain generator would be located. Another positive objective finding that's important, especially in med-legal environments, whether that be in the workers' compensation setting, in personal injury setting, or even in the independent medical examination, is known as the positive minor sign. And the positive minor sign is manifested when the patient uses their hands to push off of their thighs in order to transition from the sitting position to the standing position. So this graphic here demonstrates this patient pushing off of her thighs in an effort to unweight the load of her torso from the painful lumbar spine, from the painful and weak lumbar spine. And the minor sign is a positive objective finding. Now, the minor sign should also be repeatedly positive. In other words, you should be able to observe that each time the examinee moves from sitting to standing, they require the use of their hands to push off of their thighs to transition their movements. Similarly, the examinee who demonstrates a positive minor sign would also be unable to perform a repetitive squat maneuver. So sometimes in the medical legal setting, we'll see examinees who demonstrate a positive minor sign, but then later on in the examination procedure, when they're distracted or thinking about other things, they will successfully complete a repetitive squat maneuver, which basically recreates the same type of motion as rising from the sitting to standing position. And that would be considered an inconsistent physical exam finding. Now, in our clinical practices, we rarely see these types of symptom magnification and or malingering signs. But I just mentioned that to you here for those of you that are involved in medical legal type work. Additionally, with generalized lower back pain, we're going to see accompanying weakness and inhibition and reluctance of the lumbar spine to bear load. And that weakness can be manifested in a couple of physical examination maneuvers that we routinely employ, including the Milgram's maneuver and the prone sacrum/hip extension maneuver. So here is a graphic that demonstrates the Milgram's maneuver. And Milgram's maneuver, you should employ Milgram's maneuver along a progression. So the first stage of the progression is to simply elevate the examinee's two legs with both of your hands and allow the examinee to rest their feet in your cupped hands as you stand at the base of the examination table. Now, this examiner is not standing at the base of the table, but I recommend that you stand here at the base of the table, facing towards the patient and supporting their heels in your cupped hands. Their right foot would be in your left hand. Their left foot would be in your right hand. And then you, as the examiner, simply ask them to hold their left leg under their own power as you withdraw your support underneath that left leg. And they will either be able to support the leg under their own power or they will not. Or perhaps they'll be able to support the leg, but they will complain of pain. Now, the true objective finding on this examination maneuver is the inability of the examinee to support the weight of the leg under their own power. Simply a report of pain on this maneuver is not a true objective finding. So in other words, even though they report pain, we observe that they are able to perform the maneuver. So you would then repeat this maneuver with the right foot, asking them to hold the right foot under their own power as you withdraw support underneath the right foot. And then if the examinee is able to do both of those under their own power, you would then ask them to hold both legs under their own power as you withdraw support from underneath both of those legs. Now, a person with bona fide lower back pain and bona fide weakness of the lower back will be unable to support their legs under their own power because the lumbar spine is simply not willing to accept the load. And as you attempt to bear down or to contract the lumbar spine basically says, oh no. It says, oh no, I don't. I'm not going to load myself up. I'm not going to withhold or bear this load. And the lumbar spine basically becomes inhibited, and the examinee will give you a sign of apprehension. And they will drop their legs, or they will flex their knees in order to reduce the load of the legs, or they will give you some sort of a positive objective finding. That's known as the Milgram's maneuver. And then another useful maneuver is the sacrum hip extension maneuvers that also require loading on the lumbar spine. And in the presence of true and bona fide pain in the lumbar spine, the examinee will be unable to perform this maneuver. Now, this maneuver is also done along a progression, and the progression begins with the examinee lying flat and prone. Here shows the examinee arched at the lumbar spine, but the progression begins with the examinee flat and prone. And then the doctor asks the examinee to first raise the right leg off of the table under their own power and to raise that leg as high as they can. Now, the examinee will either be able to raise the leg or will not be able to raise the leg. Simply raising the leg but reporting lower back pain is not a true objective finding, because even in the presence of pain, they are able to raise the leg. So we ask them first to raise their left leg under their own power, and then to raise their right leg under their own power, and then to raise simultaneously both legs under their own power. Now, in the presence of bona fide pain in the lower back, the examinee will be unable to load up the lumbar spine in extension and will quickly abort the maneuver. And this is a true objective finding as they abort the maneuver. And if you've ever had an acutely painful lower back, you know that attempting this maneuver is just not possible. There's too much pain, there's too much weakness, and there's too much inhibition of the lumbar spine to permit this type of maneuver. Now, if the examinee is able to raise both legs under their own power, and yet they report lower back pain with this maneuver, this gives you an indication of how bad the pain is. If they're able to raise their own legs under their own power, the pain is not that bad, meaning that the pain is not causing significant weakness or apprehension, and the pain is not adversely interfering with function of the lumbar spine. The final progression on the sacrum hip extension maneuver is to have the examinee arch at the lumbar spine, raising their head, neck, and shoulders off the surface of the table, and then to elevate both of their legs under their own power. This is sometimes known as the Superman maneuver. And if your examinee is able to sustain and hold the Superman maneuver, even against added resistance by you, the examiner, that's a sign of preserved function of the lumbar spine. But in an acutely painful lower back situation, you will find true positive objective findings on both of these maneuvers. Now, one of the problems we face as doctors and as rehabilitation program designers is that in the presence of lower back pain, if the lower back is not properly rehabilitated through a combination of chiropractic treatments and exercise rehabilitation measures, a vicious cycle gets established, and this vicious cycle contributes to loss of optimal function of the lumbar spine. And this sets the stage for recurrent and repeated episodes of lower back pain and lower back injury. And this repeated and recurrent episodes of lower back injury is the rule rather than the exception. And I'll explain why that is in just a moment. So the vicious cycle includes the combined effects of pain, decreased function, and loss of muscular support of the lumbar paraspinal and deep paraspinal muscles that continues to potentiate more pain, further decreases in function, and further losses of muscular support. And the next thing you know is you have a patient who simply concludes that they have a bad back and that there are many activities that they're simply not able to do because, in effect, they've actually lost the function of the lumbar spine. And this is a critical component for us to recognize early on in the treatment of lower back pain cases, that it's critical for us, of course, not only to reduce pain and to alleviate suffering in our patients, but also to focus on restoring function and restoring neuromuscular control and muscular support of each of the individual lumbar spinal segments. Now, in lower back pain cases, and this is a recurring theme that we're going to see throughout this program, not only related to the lumbar spine, but also related to shoulder injuries and also related to knee injuries, is that with any lumbar pain, lumbar spine pain, whether that pain be coming from facet joints, whether that be coming from sacroiliac dysfunction, whether that be coming from lumbar sprain strain, what we see is that there is weakness and muscular inhibition of the lumbar paraspinal muscles and the deep spinal stabilizing muscles, including the multifidi, the interspinales, the rotatories, the intertransversarii, the lumbar paraspinal muscles such as the longissimus thoracis, the iliocostalis lumborum, including the psoas muscles and the transverse abdominal muscles. And you can tell a person who has a chronically painful lower back. They generally become weak around the entirety of the abdominal and lumbar spinal region. The reason they become weak is due to chronic inhibition of the deep paraspinal stabilizers and the paraspinal muscles. And this is the target of our rehabilitation efforts because incomplete rehabilitation and restoration of function of the deep paraspinal muscles and the paraspinal muscles sets the stage for recurrence and repeat episodes of lower back pain. And this was demonstrated in a fascinating study, and I've included this study for you in your handout materials. This is a study that was published in Spine magazine in December 1996. And the title of this study is simply entitled that multifidus muscle recovery is not automatic after resolution of acute first episode lower back pain. And I want to describe the results and the findings of this study for you so that you will be impressed with the necessity of proper rehabilitation of the lumbar spine. So first, let's talk a little bit about the multifidus muscle and refresh our memories on the multifidus muscle. The multifidus muscle is a long muscle that spans the entirety of the spine. It goes all the way from the sacrum all the way up to the cervical spine to insert on the base of the skull. And let's localize our function, or let's localize our focus on the sacral and lumbar spine. So in the sacral region, the multifidus muscle arises from the back of the sacrum about as low down as the fourth sacral foramen. It attaches to the aponeurosis of the sacrospinalis muscle, and it originates also from the medial surface of the posterior superior iliac spine. And then from there, these fasciculi of muscle and tendinous structures known as the multifidus muscle progress upward. Well, they progress upward into the lumbar spine, and in the lumbar spine, the multifidi originate from the mammillary processes of each of the lumbar spine vertebrae. Now, the multifidus muscle is both uni and multi-segmental. So these fasciculi of the multifidi muscles span at least one spinal segment, and they attach from spinal segment to spinal segment. So for example, in the lumbar spine, say from L5, the multifidi muscle arises from the mammillary process of L5 and projects upward to attach along the entirety of the ipsilateral spinous process of L4. So that's a single segment fasciculus of the multifidus muscle. Well, there are longer fasciculi that span a single spinal segment to attach on the next contiguous spinal segment. So in this example, the multifidus muscle would arise on the mammillary process of L5, would project upward, skipping L4, but now attaching on the entirety of the spinous process of L3. So this is a multi-segmental fasciculus. And the multifidus muscle also has trisegmental fasciculi that would then project upward, skipping now L4, skipping L3, and attaching up on L2. So these are uni and multi-segmental fasciculi that make up collectively what we refer to as the multifidus muscle. Well, because of this multi-segmental attachments, uni and multi-segmental attachments of the multifidus muscle is an important proprioceptive and stabilizing muscle of every segment of the lumbar spine. Well, amazingly, with lower back pain, pain is inhibitory to alpha motor neurons that control voluntary and involuntary control of the multifidi muscles. And you're familiar with this phenomenon, doctors, because you know that when people come in with painful lower backs, their lower back is weak. Their lower back is weak. It's unable to withhold load. It's unable to lift. It's unable to bend. And that's due to muscular inhibition of the deep paraspinal muscles and the paraspinal muscles, specifically and especially the segmental stabilizers such as the multifidi muscles. So I want to share with you the findings of this 1996 study that was published in Spine magazine. And what they did was they examined and treated 40 patients who showed up at hospital emergency rooms with first episode and acute onset of unilateral lower back pain. So this would be people that were lifting in their garage, or who had a sports injury, or who fell and hurt their lower back. But it was unilateral, and it was first episode lower back pain. In other words, these were not people that had recurrent experiences of lower back pain. These were first onset lower back pain cases. And what they did was they separated these subjects into two groups. The first group they simply treated with rest, with medications, and with work restrictions. And the second group they treated with the same rest, uh, medications, work restrictions, but also with specific exercises targeted at the multifidus muscle, the unilateral multifidus muscle. And what they noted in both groups was that on physical examination, uh, both at initial presentation to the emergency room and then weekly thereafter for 4 weeks, the multifidus muscle on the side of pain demonstrated inhibition and atrophy as demonstrated by ultrasonography. Now, with ultrasonography, they were able to measure the cross-sectional area, in other words, the size, the bulk of the multifidi muscles. And in both cases, on initial presentation, they saw inhibition and flaccidity of the multifidi muscles as demonstrated on ultrasonography. And at 1, 2, and 3 weeks of follow-up, the multifidi muscles in both cases showed atrophy, in other words, loss of cross-sectional area. So what is this? This represents loss of actual muscle tissue, likely the type 1 fibers, the endurance fibers, and also type 2 fibers, the strength and power generating fibers. In other words, the entirety of the multifidi muscle deteriorated. Now, in the group that was treated with specific exercises targeting the multifidus muscles, they found that while both groups achieved pain-free status simultaneously, they became pain-free and resumed normal activities at about 4 weeks after the initial presentation. And only the group that was treated with specific exercises targeting the multifidus muscle, only that group showed a restoration of function of the multifidus muscle. The group that was treated with rest, with medications, and work restrictions only continued to demonstrate atrophy and flaccidity of the multifidi muscles, even though they reported a pain-free condition, even though they reported a return to normal activities of daily living. And the hypothesis and the conclusion of this study is that multifidus muscle recovery is not automatic, even after the resolution of the pain in those cases involving acute first episode lower back pain. In other words, once the pain goes away, does not mean that the patient is well. It means that then the patient needs to undergo specific rehabilitation procedures, the purpose of which is to restore the function, to restore the tone, to restore the strength, to restore the bulk, and to restore the populations of type 1 and type 2 muscle fibers that make up a fully functional multifidus muscle. In the absence of such rehabilitation, this sets the stage for recurrent and repeat episodes of lower back pain. So this is a common theme that we're going to be talking about throughout the remainder of the program, and that is that pain causes muscular inhibition. Pain causes reflex inhibition of alpha motor neurons that control muscles in and around the local joint that's involved with the injury. And so there's going to be weakness. There's going to be atrophy, and this atrophy and this weakness has to be prevented at all costs, and that's a main focus of our rehabilitation efforts. Okay, so let's move forward then. With lumbago then, here are our movement and exercise guidelines. Number one is to restore strength to muscles, and number two is to establish pre-injury neuromuscular control of the lumbar spine, both uni and multi-segmentally. Well, how are we going to do that? Well, we want to implement what we refer to as spinal stabilization exercises. We want to implement balance and proprioception exercises that challenge each of the segmental levels of the lumbar spine. And we do this by also correcting postural faults that create imbalances across the lumbar spinal segments. So what are some ideas? Well, this is where stability ball training becomes so valuable. Stability ball training involves training on an unstable surface, and the unstable surface contributes to several positive effects. Number one is that it increases the abdominal muscle activity. This is the so-called core stabilization training. So it increases the electromyographic activity in the rectus abdominis, the transversus abdominis, the internal obliques, the quadratus lumborum muscles, and it increases the neuromuscular control of the lumbar spine through activation of the abdominal muscles. It activates more motor units of the stabilizing muscles than do traditional exercises, meaning traditional exercises that are predicated upon a stable platform or a stable base. See here we're talking about instability ball training. The stability ball training improves core stability and overall balance. And in addition, it activates areas of the cerebellum and the vestibular system and areas of the brainstem involved with cranial nerve number 8, the vestibular nerve, all of which contribute to posture, which contribute to balance, and which contribute to body control, and specifically related to the lumbar spine, which contribute to intersegmental stability of each of the lumbar spine vertebrae. In addition to stability ball training, we want to implement structural multi-joint exercises that activate multiple segments of the lower kinetic chain and also multiple segments of the lumbar spine. This would include, for example, squats and deadlifts. Now, the caveat with regards to these exercises is that, of course, these exercises need to begin with some constraints as to the range of motion and some constraints as to the absolute amount of loading that is applied to the lumbar spine. But progressions of range of motion and progressions of loading are important to increase the overall strength of the lumbar spine and the lumbar spine stabilizing muscles. Finally, we can progress to unstable free weight exercises, and one example that I cite here is unilateral dumbbell exercises. And with unilateral dumbbell exercises on an unstable surface, we have both an unstable load, meaning the dumbbell is an unstable load, and we control an unstable load on an unstable surface. So there's quite a bit of proprioceptive and neuromuscular activity taking place in the deep lumbar paraspinal muscles. So here's a couple of examples. Here's some stability ball exercises. This is the abdominal crunch exercise. Now, this abdominal crunch exercise, you're familiar with this, and this can be done, of course, on a stable surface, such as a stationary flat bench. But here, as the exercise is performed on an unstable surface, studies show that this increases the electromyographic activity in not only the prime movers, in this case, which is the rectus abdominis, but also in the stabilizing muscles, such as the external obliques, such as the internal obliques going this way, such as the transverse abdominis going this way, and then also in the lumbar paraspinal muscles, and even here you can see in the gluteal and hamstring muscles, there's quite a bit of stabilization going on. And this is an excellent exercise for activating, stimulating, and strengthening all the local stabilizing muscles, such as the multifidi, the rotatories, the interspinales, etc. Here's some other ideas. This is the elbow bridge. Again, this creates more of an isometric contraction through the rectus abdominis, through the quadratus lumborum. Also stimulates and activates some of the stabilizing upper spinal muscles and scapular muscles, such as the latissimus dorsi and the teres major. So with this exercise, you'll notice that the examinee is sustaining an isometric contraction here of her core as she elongates the lever through which that contraction is sustained. So you'll notice that here the fulcrum is her knees, and she's approaching here near horizontality. At maximum horizontality, we have the maximum isometric loading on all these stabilizing muscles. Here she's more vertical, and of course there's less activation of those core muscles taking place. Here there's greater activation. And for your patients that have painful conditions, one of the components of this exercise that you will want to monitor is the amount of horizontality that you permit them to assume. Those examinees who have more lower back pain and more weakness, we might take that range of motion simply through a slight increase in horizontality. Those examinees who are pain-free and who are resuming normal function will be capable of greater horizontality. With regards to structural and multi-joint exercises, here is an idea of how to implement squats in a way that provides very little loading to the lumbar spine, but does allow the activation of multiple lower extremity joints and also the entirety of the lumbar spine segments. One of the beautiful things about resistance bands is that resistance bands increase their tension as the patient assumes a more upright and completely extended position. As the patient descends into greater and greater depths of the squat, the resistance band slackens and tension on it reduces. And this is perfect for those examinees who are weak in the lower back, in the greatest position of hip and lumbar spine flexion. So in those positions, the resistance would be minimal and would consist basically only of body weight. But as the examinee assumes a more upright position and strength increases nearing maximum extension, then they get some added resistance from the resistance band. So this is a very safe way to introduce multi-segmental, multi-articular, and large muscle groups in the early phases of lumbar spine rehabilitation. Here is another excellent exercise. This is known as the Romanian deadlift. And I love the Romanian deadlift as a way to exercise and rehabilitate the lumbar spine. And what's good about the Romanian deadlift is that if the Romanian deadlift is done properly, it allows a muscular loading of the lumbar spine in the absence of axial, articular, and axial disc loading of the lumbar spine. So you'll notice here the patient has two dumbbells. They're held very close to the front of her legs. And as she descends into hip flexion, you'll notice that the lumbar spine remains straight with a normal lordosis and no flexion of the lumbar spine. So this is a sustained isometric contraction of the lumbar paraspinal muscles and intersegmental stabilizing muscles. There is no spinal motion taking place in this particular movement. The spine remains unflexed and the spine remains neutral. The entirety of the motion takes place here at the hip joint. So this is a fabulous way to introduce muscular loading to the lumbar spine in the absence of axial loading to the joints, to the discs, to the bones themselves. And so this is a excellent progression to begin with. Now, for those examinees that have active pain in the lumbar spine, this might be a movement that you want to start simply with no weight in the hands. And another variable that you would want to control would be the depth of the range of motion of the descent phase of this exercise. Now, I want to talk to you a little bit about the descent phase of this exercise. You'll notice that as this athlete descends, the motion that's taking place here is hip joint flexion, or we could call this sacral flexion around a fixed hip. It's sacral or hip flexion, however you want to look at it. Now, there comes a point in time when the hamstrings achieve their maximum length and they become unable to further stretch across both the hip joint and across the knee joint. When the hamstrings reach that maximum length, we refer to that maximum length as their active, as the passive insufficiency. The hamstrings have reached passive insufficiency, meaning that the hamstrings can no longer elongate across the hip and knee joints simultaneously, and the athlete is unable to descend any further into the movement. Now, if the athlete does descend further into the movement, that additional movement is coming from lumbar spine flexion rather than sacrum or hip flexion. Now, you'll know when your patient has reached passive insufficiency because the knees will start to bend. As the hamstrings reach their maximum length, we have to relieve tension at some point. And the athlete will do that by bending at the knee. So when the examinee bends at the knee, you know that they've reached passive insufficiency and the descent phase of this exercise is completed. If they descend further, they're likely going to be substituting lumbar spine flexion movement for hip flexion movement, and that's not something that we want to do. Finally, here's some examples of some unstable and free weight exercises using dumbbells. Now, the benefit of using dumbbells is that the dumbbells themselves are unstable. They're much more unstable than is, for example, a fixed bar that you would simply hold with two hands overhead. The dumbbells introduce an element of instability for each of the upper extremities. And that instability, of course, is transmitted through the upper extremity, through the scapula, and through the entirety of the spine. So the dumbbell training is excellent for introducing instability and increased activation of the spinal and scapular stabilizing muscles. This will be important also when we get to discussion of the shoulder. Well, in addition to the instability offered by the dumbbells, here we see the patient on an unstable surface. So we have an unstable load being lifted across an unstable surface. And of course, this requires tremendous activity and tremendous contraction of the spinal stabilizers, hip stabilizers, scapula stabilizers, and the entirety of the posterior chain of muscles. Here's an example of an unstable load on an unstable surface now in the upright position, and this of course requires tremendous core activation and stabilization. Otherwise, this athlete or this patient would simply fall over onto the floor. So these are some ideas to rehabilitate and prevent recurrence of generalized and nonspecific lower back pain conditions. And some of these principles will apply to the rehabilitation of all lumbar spine conditions, because one of the common and recurring themes that we talked about is the inhibition of the deep spinal stabilizing muscles. And these are some exercises that will basically become core exercises for your patient moving forward for the prevention of future occurrences of lower back pain.